ओपन कर दूं रूम को?
या ओपन कर दो।
ओके भाई।
Oh, 20 people, good.
Good evening.
Monica, 5 o'clock we can start.
Good evening, Naveen.
Good evening, sir. Welcome, Dr. Joshi and Dr. Parmanand Jain, sir. Good evening, sir.
गुड इवनिंग।
Namaskar, everyone, and a very warm welcome to Saarc Association of Anesthesiologists CPDP program. This is the second session, and I would request you all to kindly be muted. All your questions can be typed in the chat box, and they will be taken up later on. Now, at the outset, I would like to request Dr. Naveen Malhotra, Secretary, Saarc Association of Anesthesiologists, to welcome the gathering. So please.
Good evening, all. Namaskar. Welcome to the second session of KACPDP, continuous professional development program. And it is the continuation where we left in the previous inaugural issue. And we have got very good topics lined up on neuropathic pain and cancer pain. The eminent faculties from Nepal and Bangladesh will be sharing their inputs with us, and they will be ably chaired by respected seniors from Bangladesh, Nepal, and India. And I'm especially thankful to Dr. P.N. Jain, sir, Dr. Joshi, sir, for accepting our invitation to chair these sessions. And I also warmly welcome Madam Vasumati Divekar, the founder president of Saarc Aa, who has shown her very, very keen interest in joining all the programs of Saarc Aa, because it was during her time that Saarc Aa was formed and she was the founder president of Saarc Aa. I also welcome my colleagues, treasurer partner Dr. Virendra Sharma and Dr. Anjali Bhure, the executive member, and other distinguished delegates. And Monica, please do invite Madam Vasumati Divekar for a few words after Dr. Giri. Thank you very much. Looking forward to a nice academic interaction.
Thank you so much, sir. Now, I would like to request Dr. Vasumati Divekar to please address the gathering with her few words.
Can you hear me?
Yes, ma'am.
It's a great pleasure to be here because it was in the year 1993 that we started the first meeting in Dhaka. And I'm very glad to be here. And I'm so glad that you have revived it now once again. It was a little dormant for a few years. And I wish you all the best in this program on pain. Dr. Malhotra, of course, as you know, is a great contributor for pain management in India. And thank you all for inviting me.
Thank
And
you so much, ma'am.
also welcome the delegates from Nepal and Bangladesh. I remember Dr. Chowdhury and Dr. Shrestha Amartya. Okay. Thank you all.
Thank you so much for joining us, ma'am. Now, I would like to invite Dr. Venkatagiri KM, President, Saarc Association of Anesthesiologists, to say a few words. Sir, please.
Naveen, can you hear me?
Yes, sir. We can hear you. We are the host. Dr. Giri, please unmute yourself.
Okay, thank you. Good evening, everybody. Past Saarc President, Madam Divekar, Saarc Office Bearers, Vice Presidents, Secretary Naveen, ISA past President Dr. Joshi, President-elect Dr. Balavenkat, he must be there. He told me that he will be joining at 5:58. He was in some other meeting. I did not check that whether he's there. He told that he will be joining. And stalwarts of pain, Dr. Jain, Dr. P. Kumar, and Dr. Anjali Bhure, all friends. Good evening.
Muralidhar Joshi.
After a small gap, we are again. Dr. Muralidhar Joshi, yeah. Dr. Muralidhar, I told him as a past president, not as a pain, because he's a pain person also. And so I did. And I say that Dr. Balavenkat, not only our president-elect, he is a secretary of WFSA also, and Dr. Vinodini from Sri Lanka, and vice president from all the Saarc countries. Good evening. We started a good note, and due to some technical problem, we could not have a meeting in the last month, but never the bad. We are again now having this meeting, and we hope that we will have this meeting with the different Saarc countries, faculties every month to.
You're not audible, Dr. Venkatagiri.
I hope you all will enjoy this CME, and I don't want to come between the faculty and you. Wish all the best and chronic pain, and you will improve your knowledge and your skill will be better after hearing.
Thank you so much, sir. Thank you, sir. Now, I would like to invite Dr. Balavenkat Subramaniam to address the gathering with few words. Sir, please.
Thank you so much for that invite and doing the MC, Dr. Monica. President Dr. Venkatagiri, Secretary Dr. Naveen Malhotra, and Treasurer Dr. Virendra Sharma of the Saarc AA group. And I think it's extremely crucial and important that we all have to come together, work together, and grow together in an atmosphere where Asia and Southeast Asia have to show to the world the phenomenal contributions that we do by the clinical work, expertise, and experience that each one of us gather. I think this platform and forum is important because all the work that we do should be discussed in the web meeting like this. More importantly, to make these presentations and these thought processes into black and white, publish it, add to the literature, show to the world that we contribute a lot. I think this is probably the need of the hour. And the world knows that we do a lot of work because of the phenomenal amount of population and the clinical work, but they do not know that we do high quality work. So platform like this, sessions like this will promote mutual understanding between the Saarc group of countries, where we learn from each other. There are occasions where we have certain limited resources, but we still do excellent clinical work with excellent outcome. And all this has to be collated, and we need to emerge as a strong force. And I'm very happy that this initiative has been done, and we look forward for more collaborations between all the societies. I also take this opportunity to welcome you all to the next World Congress of Anesthesia in Morocco in 2026. I'm giving an early invitation to block your dates, April 2026, and the website will be launched very soon. And thank you so much for giving me this opportunity. And I'm sure we are going to gain a lot from the session that is in store for us. Thank you.
Thank you so much, sir. Now, I would like to invite Dr. Anjali Bhure from India, EC member, Saarc Association of Anesthesiologists. Ma'am, please introduce the webinar.
Thank you, Monica. A pleasant evening to all of you. I bring greetings from India. Honorable President Dr. Venkatgiri sir, Dr. Naveen Malhotra, Secretary, Dr. Virendra Sharma, Treasurer, other distinguished office bearers, senior teachers, Divekar ma'am, Jain sir, Tarlika ma'am, P. Kumar sir, esteemed faculties and distinguished chairpersons, and my dear friends. It is imperative that anesthesiologists have opportunities for academic advancements to keep up with the fast pace at which developments have already taken place and are continuing to do so in our specialty. Saarc Association of Anesthesiologists, under the banner of Continuous Professional Development Program, is aiming for achieving academic excellence. Now, in this series of webinars, the previous webinar, which was held on 23rd of Feb 2024, and the topics covered were myths and controversies in labor analgesia. The deliberation was by Professor Madhusudanam Upadhyay from India, and facial pain by Professor Saman Nanayakkara from Sri Lanka. Please forgive me if there is some spelling mistake. So, today at the outset, I would like to invite our esteemed chairperson for the first session, Dr. M.D. Khalilur Rahman. He is Honorary Consultant, Department of Anesthesiology, Surgical ICU and Pain Medicine, Burdem General Hospital and Ibrahim Medical College, Dhaka, Bangladesh. He is Advisor, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physicians, BSA CCP. Past President, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physicians. I welcome you, sir. The second chairperson which I would like to invite is Professor Dr. Debabrata Bane. He is Dean Nursing Faculty, BSMMU, Professor in the Department of Anesthesia, Analgesia and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University. At the moment, he is President, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physician. I welcome you, sir. The next chairperson I would like to invite is our own Dr. Muralidhar Joshi. He is Group Head of Pain Medicine and Senior Consultant of Anesthesia. His area of special interest being pain education, interventional pain management. He has written 6 books and many articles. He is first to start fellowship in pain management in India. He is a recipient of academic excellence in the year 2010 by Indian Society of Anesthesiologists. He is president in the year 2023-24 of Indian Society for Study of Pain. He was president 2019-21 Indian Society of Anesthesiologists. He was member WFSA Safe Anesthesia and Quality of Practice Committee 2020 to 2024 and is member of WSA Pain Relief Committee from 2016 to 2020. And let me tell you one thing about him, that his books find space in every medical college of India. Dr. Muralidhar Joshi. I welcome you, sir. The available pharmacological approaches are effective on one or the other types of chronic pain. But the inadequate pain relief and limitations with each class of drugs raises the need to develop better therapeutic approaches and also understands the pathology better. So I would like to invite today's speaker, Dr. Professor Kawsar Sardar. He is head of the Department of Anesthesiology, Surgical ICU and Pain Medicine, Birdham General Hospital and Ibrahim Medical College, Shahabad, Dhaka, Bangladesh. He is Secretary General, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physician, BSA CCP. Vice Chairman, Section of Bangladesh, India and Sri Lanka, World Institute of Pain. Member Education Committee, World Institute of Pain. And he is examiner for FIPP, World Institute of Pain. He is secretary for the organizing committee of upcoming 15th Saarc Aa conference at Dhaka, Bangladesh. Now, before we begin, there's just a polite reminder to put your queries or questions in the chat box, all the attendees. This is a simple request to all of you. Over to Professor Kawsar Sardar for his deliberation.
Just before that, we recognize presence of our treasurer, Dr. Virendra Sharma, the secretary of ISA National, Dr. Bajwa, and other dignitaries present here. Thank you.
Thank you, sir. Over to Dr. Kawsar Sardar, please. Sir,
Yeah,
for your
Dr.
Anjali,
Aryan, who is the Bangladesh, who is the Afghan president, also present today. We recognize his presence also. Dr. Nurul Aryan.
okay, Anjali,
Thank you, sir.
can you hear me?
Yes, sir.
Okay, can you see me on screen?
Yes, sir.
Yeah, but I can't see myself here. Okay, no problem. So thank you very much for your nice introduction to me, and really we are grateful and very much thankful to organize the current Saarc Aa committee, and especially want to thank Dr. Naveen Malhotra and Venkatagiri as the secretary and the president of the current Saarc Aa to organize such a beautiful Saarc Aa continuous development program routinely in this Saarc region. Definitely, it will be very helpful for the development of our bilateral and multilateral improvement in the medical science in the Saarc region. And I am very much happy to see some very renowned figure from India. P.N. Jain sir here, Muralidhar Joshi sir is here, and very especially madam, that is the Basmati Divakar madam is here, and we have been really thankful to Dr. Balabhaskar Subramaniam, is the current secretary of World Federation of Society of Anesthesiologists, recently elected. We are proud of him. We are really happy to have you here. So right now, I think the two chairperson already joined, Professor Devabutra Bonik and Khalil Rahman sir. Okay. So I'm sharing my screen right now. Huh? Okay. Can you see my slide?
Yes, sir.
Okay,
Yes,
thank you.
yes, yes,
Okay,
Kausar, sir.
thank you. So my topic is the evidence-based drug selections for the neuropathic pain. So those who we are the pain physicians, we see multiple prescription which is done by the different disciplines is very much haphazard for the neuropathic pain. The drugs is very specific which drugs is to be prescribed. This is a very important part of the treatment, but we usually don't see that it is in the right form. So as pain physicians, we have to guide all the discipline how to prescribe a neuropathic pain drugs for the neuropathic pain condition. So this is my disclosure to this presentation. So how do neuropathic pain sufferers express? Like this, neuropathic pain sufferers, this is the expression actually. I feel as though someone has taken a hot cooker knife and is jabbing it deep into my right eye. If I could pull my eye out only to remove the sensation, I would gladly do so. Sometimes I think death is better than sufferings. So this is the expression sometimes some neuropathic pain patients express to the pain physicians in this way. So what is the prevalence? The Van Heck published a neuropathic pain in the general population, a systematic review of epidemiological studies in 2014. He showed it is 7 to 10% of the general population it is. It is not so less actually. 7 to 10% per general population is a good number, I think. So these are the different neuropathic pain conditions what we encounter in our OPD, cervical or lumbar radiculopathy, failed back surgery syndrome, post-traumatic, post-surgical neuropathic pain, spinal cord injury, trigeminal neuralgia, multiple sclerosis, central post-stroke pain, complex regional pain syndrome, diabetic neuropathy, cancer-related pain, like this, fibromyalgia also in the list, and many more. And what is it? This is the simple model of the pain pathway where the transmission, modulation, and perception is the main key. This is the simple pain pathway, but for the neuropathic pain, this is different. That's why the drug selection is different than the normal pain. This is the physiological pain. Some changes happened in the different level of the pain pathway, especially in the peripheral nerve fibers. There is ectopic discharge is there, collateral sprouting is there, nociceptive sensitization is there, and some crosstalks also with the sympathetic fibers. It complicates the situation. And in the spinal cord level, there is the spinal cord anatomical reorganizations happened here. There is a dorsal horn denervation sensitivity and the molecular changes happened here. In the brain level, there is a molecular change happened here. That's why the neuropathic drugs is depending on the different changes happened here. So why the neuropathic drug selection is very challenging in neuropathic pain? So it's a very complex structure you see from the periphery to center. That is the changes in the peripheral, in the receptive level, that is in the terminal, in the nerve terminals, in the dorsal root ganglia level, in the presynaptic first order neuron, the postsynaptic second order neurons, and the go-ons up to the cerebral cortex in the sensory area 3 to 1. There is a lot of changes happened in the neuropathic pain. That's why it has to address the proper drug selections for different changes in the different levels. The ion channels is important also, and immune response also important. Some ion channels, like the sodium channels, there is a up regulation of the sodium channels in the neuronal tissues, and there is a cluster of the sodium channels accumulated in the neuropathic pain scenario. And same for the potassium channels, also some changes happen, and also for the calcium channel too. And immune system also important for the neuropathic pain, like it also important for the acute and the neuropathic pain both. In acute pain, you see some research that shows that in inflammatory condition, there is some immune change they have shown in the peripheral level. There is when the inflammation is subsided, the immune response is go down to the normal level. It has been shown many studies. And for the neuropathic pain, there is some immune cell invasion in the Schwann cell. This also reported by some other researchers. So that's why this thing also important for the neuropathic pain management should be considered. So basis of the drug selections for the neuropathic pain. This is the excitatory and the inhibitory neurotransmitters should be kept in mind for the proper selections of the drugs for the neuropathic pain. And ion channels also important to select the proper drugs for the neuropathic pain. So this is the glutamate and the substance P storming. These changes happened in the neuropathic pain in the presynaptic level. You see the huge glutamate, which is a very excitatory neurotransmitter. Its number is increased tremendously in the neuropathic pain condition. So it discharges from the presynaptic to synaptic cleft and actions for the postsynaptic membrane, and subsequently the glutamate and the GABA cascade is important. So there's glutamate always this balancing. It actually breaks down in the neuropathic pain condition. So glutamate is the excitatory neurotransmitter, whereas the GABA is an inhibitory neurotransmitter. So this cascade is when in the glutamate is taking the upper hand, so the pain is expressed by the patient will be more. And in the neuropathic patient, it happened the glutamate and GABA balancing it's destroyed. The glutamate and the glycine balancing. So the glycine is inhibitory neurotransmitter in the spinal level, and this balancing is also important, like glutamate and GABA balancing the same way. Another two important neurotransmitter, that is the serotonin and norepinephrine. Serotonin is an inhibitory neurotransmitter. Norepinephrine has both it's a inhibitory and as well as the excitatory. For the neuropathic pain, for the neuron, so norepinephrine is only for the neuropathic pain is it plays as a inhibitory neurotransmitter like serotonin. So, and another important one is the opioid-based inhibition. So, opioid-based inhibition, it's a important drugs that inhibits and it facilitates the descending analgesic pathway and plays a role in the dorsal horn in this playground. So what is the evidence for the drug selection? That is the anticonvulsant, antidepressants, and opioids and other drugs. Other drugs like sodium channel blocker, like lidocaine and the capsaicin. These are the drugs. Evidence says about this 1, 2, 3, 4, and 5 types of drugs is in favor of the neuropathic pain treatment. And there is no role for the NSAIDs actually for the neuropathic pain. So how do antidepressants is so,
Dr.
there
Sardar,
is
go
some,
for full screen, full screen.
yeah, there is some issues here. Okay. Is it okay? I think it is okay. I think so. How does anticonvulsants works in the neuropathic pain? It is the carbamazepine and the gabapentin. It blocks the sodium channel. It works with a sodium channel block. Gabapentin and pregabalin, it's a block the calcium channel and not moving.
The slides are not moving.
Okay, it is moving right now, I think so. Okay, okay, sorry for the interruptions. Then carbamazepine, it has the actions on the enhancement of the gamma-aminobutyric acid, which is a inhibitory neurotransmitter. And the carbamazepine, gabapentin, and the pregabalin, it suppress the glutamate. So the drugs has actually multiple mechanism of actions to reduce the pain in the neuropathic pain patient. So here you can see how the GABA enhancement of the GABA is important to reduce the excitatory activity of the glutamate to encounter the GABA. The gamma aminobutyric acid is important, and it works in the alpha 1 and beta 2 subunits and
Excuse me,
enhance
sir.
the.
Sir,
Yeah,
excuse me. I think the slides are not moving, sir.
lights are not moving,
Yes, sir.
but here it is moving. Can you see it is moving right now?
No, sir.
Sorry,
The
stop
first
sharing.
slide is visible.
No?
No, sir. You are on the first slide, sir.
I'm in the first slide.
Ji, sir.
Okay, I'm
Can you
stopping
restart the presentation? Yeah.
Okay, I'm stopping the sharing and again I am joining.
Yeah. Please do so. Thank you.
Is it moving right now?
Yes, sir. Yes,
Okay.
sir. Thank you.
Okay, thank you for. Okay. So I was here actually. So and the pregabalin, it actually blocks in the presynaptic level in the calcium channel in the alpha 2 and delta subunits, and it prevents the calcium inside in the presynaptic level, and ultimately it is stopping the excitatory neurotransmitter like glutamate. That's how it actually inhibits the pain propagation. And so voltage gated sodium channel is another important. The carbamazepine actually it blocks, it inhibits the sodium influx in the postsynaptic membrane, and it stops the pain signals. So how do the antidepressant works in the neuropathic pain? So antidepressants like secondary amines, desipramine, nortriptyline, it inhibits the norepinephrine reuptake only, and but the tertiary amines like amitriptyline, imipramine, and duloxetine, venlafaxine, inhibits both norepinephrine and the serotonin reuptake. That's why in the synaptic cleft level, that increases the concentration of the norepinephrine and serotonin. For the amitriptyline, additionally, it also blocks the acetylcholine reuptake also. So that's why the side effects is more in the amitriptyline than the duloxetine, that is the selective norepinephrine and noradrenaline and serotonin and noradrenaline reuptake inhibitors. So you see here how the acetylcholine, here is the serotonin is discharged from the presynaptic membrane, and norepinephrine discharged from the presynaptic membrane, and acetylcholine also discharged from the presynaptic membrane, and that is the tricyclic antidepressants. It's a prevent all three reuptake, but for the SNRIs, it blocks only the reuptakes of the serotonin and norepinephrine only. The systematic reviews of the anticonvulsants drugs, it says review, it's my own publications. It's published in 2016, anticonvulsants and the antidepressants in the chronic pain scenario. And we took about the GABA 14 studies and 14 studies for the gabapentin and the pregabalin in the various neuropathic pain condition. And the NNT number was the 4.3 to 6.4 for the gabapentin, and for the pregabalin it was 3.8 to 4.8. For the trigeminal neuralgia setup, carbamazepine, we took 2 clinical trials, and its NNT number was it's a little bit good. And NNT number, so number needed to treat closer to 1 is good. That is, if the number is 1, this is very good. If number is up to 5 is considerable, the drugs is working very well to the treating scenario, and 5 to 10 is considerable, and above 10 is non-considerable for the NNT. So for the post-herpetic neuralgia pregabalin, we took 8 clinical trials. For the gabapentin, 4 clinical trials. NNT number shows 3.9 to 5.3 for the pregabalin, and the gabapentin is 4.3 to 7.7. And for the diabetic neuropathy, for pregabalin and the gabapentin, it is showing the 5 to 11 is the NNT number, and for the gabapentin, it is 4.7 to 28. So central neuropathic pain for the pregabalin, it is 3.5 to 14 is the NNT number. For the systematic reviews for the antidepressants, that is in the various neuropathic pain condition, amitriptyline, desipramine, and imipramine showing 2.5, 1.9, 1.7 NNT number. And for the TCA, SSRIs, and SNRIs, it is showing 1.9. TCA showing 1.9 is a very good number. For the diabetic neuropathy, duloxetine, it's showing 5 to 10 is the NNT. These are the different guidelines published by the different organizations like European Federation of Neurological Society, published in 2007 on the pharmacological treatment, and it's updated in 2010. Canadian Pain Society published in 2012 the interventional treatments guidelines, and Canadian Pain Society also published another pharmacological treatment guidelines for the neuropathic pain in 2007 and updated in 2014. And some other like IASP, Neuropathic Pain Special Interest Group, published in 2007 and 2011 updated the pharmacological guidelines for the neuropathic pain, and also published for the intervention in 2013. And there is a nice guideline in 2010, it published and updated in 2013, the base of the pharmacological treatment for the neuropathic pain. And
sorry to interrupt you, sir. We only have 2 to 3 minutes more.
Okay. I'm going first. So some consensus statement also, but in South Africa, in Latin America, and in the Middle East also published what the recommendation by the guidelines of the above, the first line drugs by the ISSP for the neuropathic pain is the gabapentin, pregabalin, norepinephrine, bezipramin is the first line treatment by Canadian Pain.
Dr. Giri, please mute yourself. Dr. Giri, please mute yourself. Dr. Venkat Giri, please mute yourself.
Dr.
Kausar, please go
you
ahead.
can unmute now. So please unmute yourself.
Okay. Am I audible now?
Yes, sir.
Okay, thank you. The Canadian Pain Society recommended the first-line drugs is the pregabalin, gabapentin, tricyclic antidepressant, carbamazepine for the trigeminal neuralgia only. So European Pain Federation, Latin American NICE guidelines, and the Middle East and the South Africa, their consensus meeting, they declared the first-line drugs for neuropathic drugs like this. And for the my slide is not moving right now. Okay. So for the second line drugs recommended by the ISSP, Canadian Pain Society, European Federation, Neurological Societies, and so on, so like this. This is the third line drugs, and this is the recommended fourth line drugs for the neuropathic pain. So in conclusive recommendations for the pharmacologic interventions for the neuropathic pain, recommendation for the anticonvulsants is the gabapentin and the pregabalin have been recommended as the first-line therapy, with the exception of the trigeminal neuralgia by European Federation of Neurological Societies, Canadian Pain Society, and ISSP, Neuropathic Pain Special Interest Group. Carbamazepine has been recommended as first-line therapy for the trigeminal neuralgia by European Federation of Neurological Society and Canadian Pain Society. And tricyclic antidepressants have been recommended as first-line therapy by the European Federation of Neurological Societies, Canadian Pain Society, and ISSP. And SNRIs as second-line therapy because of the suggestive estimates efficacy lesser than TCA by European Federation, Neurological Societies, and Canadian Pain Societies. But SNRI is considered as first-line therapy due to more favorable side effects profile by ISSP Neuropathic Pain Special Interest Group. Tramadolol and the morphine considered as a second-line therapy by the European Federation of Neurological Societies, Canadian Pain Society, ISSP, South Africa, Latin America, and Middle East, consensus statement. The recommendations for the lidocaine patch, that is the 5% lidocaine patch, considered as the first-line therapy by ISSB Neuropathic Pain Special Interest Group and the Latin America and the Middle East consensus statement. And for the capsaicin, is considered as the second-line therapy by European Federation of the Neurological Society, and capsaicin is considered also, as the third-line therapy by ISSB Neuropathic Pain Special Interest Group. In conclusion, I want to say that find out the cause is very important for the neuropathic pain. What is the cause? So if there is very specific cause, so remove the cause is the best way. And second is that avoid the extra drug load always. So extra drug it invites the side effects unnecessary. So right choice of the drug according to the guidelines is important. If fail conservative or intolerable side effects, go for the interventional pain techniques. And though it is not the today's topic, intervention are also some good guidelines for the interventions for the neuropathic pain also. So thank you very much. Thank you all.
Thank you very much, sir. Monica, can we have the question answer session?
Sure, ma'am. As of now, in the chat box, there are no questions. If someone have any query, they can just raise hands. You can take them up. It can be questions or any point of discussion.
Dr. Kausar,
Yeah.
Joshi here. Muralidhar Joshi here. Don't worry. Don't
Yeah.
don't try to look for me. No, I just wanted to understand, because I just want to understand how often you see probably B12 deficiency in Bangladesh and then or vitamin D deficiency, or is it being overexploited? Vitamin B12 and vitamin D3 investigation, is it being overexploited? Your observation.
I can't hear actually properly. Can you repeat the question, please?
Vitamin B12, vitamin D3.
Yeah.
Deficiency gets recorded so often in India.
Yeah.
How much it is clinically relevant in your country?
Yeah.
Of course.
Vitamin D3, it is recorded in Bangladesh. It's a subnormal level actually. A healthy patients, they have no issue actually. But patients have the hypo level like 15, 20 or 25 like this. But patient have no problem. And patient is, and it's like normal people, those who are working in the sunlight every day, we go for the vitamin D3 level check, but they have still the lower level of the vitamin D3. And about B12, we have not too much data about it, but maybe what is the Indian experience about vitamin B12?
B12, we do get the deficiency usually in vegetarians in India.
Yeah.
D3, same problem as what you have. Like quite often we get a lot of people on the lower side, but they're not symptomatic. The question here is, are we overestimating the problem unknowingly and trying to treat them is about, because the cost of vitamin D D3 investigation is much higher than the treatment itself.
Okay.
Because as you rightly said,
important
Bangladesh,
point. I am thinking that there is any defective in the investigation, laboratory finding. For one man in different laboratories, there is a finding is difference.
So Bani sir, it's not like that. What I'm trying to say is, are we penalizing our patients? Is what I'm trying to say. Not the lab. It's not a lab issue. People are comfortable. See, we are all brown people. Say, for example, our skin may not absorb vitamin D3 that much compared to some other group and all. But question is, they're not symptomatic and they're comfortable. Only thing is, I have found in some group of patients, some groups where they had radical symptoms, but they had very low vitamin D, less than 10 or less than 5. Then with the shot of vitamin D, they improved a lot on that. We didn't have to do anything else at all. I'm just looking from the technical point of view. What we are seeing, is it same over there also? Both are adjoining countries. Basically, we're all part of the same family.
Yeah. What happening here actually? The doctors of different disciplines, they prescribed always any neuropathic pain condition or any nerve
Calcium and vitamin D.
vitamin B1, B6, and B12 combination. There is a one tablet is available here. They prescribed it without knowing what is the level of the B12, what is the level of the B6, what is the level of the B1. Yes, this is true for the nerves, for the repairing of the nerve damage or keeping in the physiological state. Vitamin B1, B6, and B12 has significant role, but without knowing the level, should not prescribe actually. But here in Bangladesh, vitamin B12, some laboratories they do it for vitamin B1 and B6. No, I don't know which laboratory do it. Only vitamin D12 I know they tested for it. But blindly they prescribe. They prescribe this drugs. This is very unfortunate, I think.
Mr. Joshi,
Yes,
what are
sir. I'm around.
in your prescription, in your country, or there is any guideline to how much with reduction you can prescribe with the vitamin D or calcium most?
So, question as I rightly pointed out, the question we are going with currently with the international guidelines, but the question is quite often we are feeling in the clinical, I should say, practice that we are trying to overestimate. See, for example, people who are happy with your 10 also, or maybe then why when the lab says that it should be 25 to 30 or something, 20 to 30, depends on the kit what you use. Then he is comfortable, and then we see that we try to treat also, never had any side effect as such. But we are looking at it, are we trying to give the higher range just for the heck of it, or should we really go with probably should we modify the levels actually? That's what we are contemplating. That's where I wanted your inputs from Bangladesh. What we are seeing, is it the same? Because so we have enough sunlight, both your country and our country. That's not a problem at all. Sunlight is not a problem at all. And as Kausar rightly pointed out, that people work in the sunlight day in and out like a fisherman and all. Where the question of shortage of sunlight for them.
Very young patient have also a low level of vitamin D3 one is investigate.
I think, sir, it's my observation. Of course, somebody can correct me also, that we are overestimating.
Yeah.
What do you think?
This is true, Joshi. And vitamin D3, this is well discussed actually every level. But what you have raised about the vitamin B, this is not discussed in the other discipline. And so what I feel actually from our society, we can recommend one thing. So don't give any vitamin B1, B6, and B12 without seeing the level of the vitamin inside the individual patient. So I think, but still there is no guideline I found about this. But this recommendation, I think a lot of people they are taking these unnecessary drugs, though it is water soluble drugs. This is the benefit only. There is no side effects actually. If it is well soluble, so it may be harmful for the patient, but this is the only thing they can prescribe these drugs, and it will not harm too much to the patient. but still the financial issue, this tablet, this three combination is not too less actually. So why the patient should bear too much money unnecessarily? Yes. They're keeping it inside body, and just in the morning they micturate the whole thing. So it should not be.
So we have other questions. Can we take them up?
Yeah, please go ahead, madam. Please go ahead.
So Dr. Mohan has asked, which drug is helpful in chemotherapy-induced neuropathy?
Yeah, chemotherapy-induced neuropathy. Okay, yeah, chemotherapy is a first of all, for the cancer patients, why the cancer patient is painful, when the nerve is involved in the cancer pathology, like any pressure effect by the cancer itself, so it produces pain. And to reduce the cancer cellular size, cellular activity, the oncologist use the chemotherapy. And chemotherapy also injured the not only the cancer cell, it also injured the nerves around it. So ultimately, so any drug injury to the neurons, it ultimately produce pain. So that is the cancer therapy induced pain. This is also part of the neuropathic pain, and that should be addressed in the management plan. If I could understand the questions, what he or she has asked about.
Yeah. So our next question is, sorry, please go ahead.
Can I ask a question? I am Dr. Shukharanjan Das from Bangladesh.
Yeah.
Sure.
Yes, sir. Good afternoon, sir. Sir, I have two questions. Sometimes we use anticonvulsant, antidepressant, and SNRI along three drug accord. So have any recommendation, but have any guideline and their uses of accordingly, or how long? And another question is, how long time we can use this drug?
Okay, I have shown the different guidelines, like what IASSP stand, what is the stand of European Society of Federation of the Neurological Society, Canadian Pain Society, NICE guidelines. All says about the anticonvulsants and antidepressants is the drug of choice for the neuropathic pain. And for the anticonvulsants, this is the second generation drugs, that is the pregabalin and the gabapentin, not the phenytoin and benzodiazepines. These are the first generation. Only the second generation is recommended for neuropathic pain, and with special for the trigeminal neuralgia is the carbamazepine is the drug of choice. This is the anticonvulsants drug therapy guidelines for the almost all societies of the world. And for the antidepressants, yes, it's a tricyclic antidepressants is the choice of drug for the neuropathic pain by the all societies. And SNRIs is recommended by the IASP because of the lesser side effects profile than TCA. So this is the recommendations from the different societies for the antidepressants. And your second question was how long? So yes, how long? There is no guidelines for the how long actually, but the pain, if it works, if the side effects not is a problem or side effect is not coming, so you can continue the drugs. And every drugs have some side effects also. The patient should accept the side effects like other drugs. So if you see like this, the anti-hypertensive drugs, if you see the side effects of the antihypertensive drugs, you will get a big list. So if you see the side effects of the anti-diabetic drugs, so you will get a lot of dangerous things. So it is continuing lifelong, like anti-diabetic, anti-hypertensive. So neuropathic drugs is like this. So if the patient have the neuropathic pain, so it can continue lifelong, accepting some side effects. I think you got the point.
Thank you, sir.
So our next question is, what is the role of patches for neuropathic pain, like fentanyl patch or any other analgesic patch?
Yeah.
Can we use it for neuropathic
So
pains?
there is the three type of patch. Is like one is the lidocaine patch, that is the sodium channel blocker actually. So 5% lidocaine patch, it works very well because it blocks in the peripheral level, that is at the terminal end of the nerves, that is at the transduction level. So pain will not, the stimulation will not influx the sodium inside the neuron. So it blocks it here. So it is fantastically, it works. Number two is the capsaicin patch. Capsaicin is ointment. So 0.025% capsaicin is available in this region. So it inhibits the substance P, which is a excitatory neurotransmitter in the peripheral tissue. So it inhibits the activity of the substance P. And for the fentanyl patch, yeah, it's a absorption by the peripheral circulation. It keeps in the central circulation, and it works in the mu1 receptor everywhere, and it stops the pain, especially in the dorsal horn level. It works. It works. These three works very well.
Dr. Tarlika wants to ask, what is your experience in treating scar-related neuropathic pain? If anyone wants to answer, respected chairpersons or the
Yeah.
speaker.
What's the question? I missed actually.
Yeah, it is about the treatment of scar-related neuropathic pain.
Scar-related neuropathic pain treatment. Yeah. So yeah, for the neuropathic pain scenario, the guideline is saying, so you can give both. That is the anticonvulsant and antidepressant combination. Most preferably, according to side effects, is less in the pregabalin. Gabapentin, it needs huge dose. So pregabalin, it has less side effects than the gabapentin. So you can choose pregabalin from the anticonvulsant side. And you can add one antidepressant, selective serotonin norepinephrine reuptake inhibitors is good for that. You can add also tramadolol hydrochloride with it, because tramadolol hydrochloride has a dual effect. That is, it works in the mu receptors as well as it is serotonin reuptake inhibitors. So it increases the serotonin level in the synaptic cleft. So it works very well. So what I was telling, number one is anticonvulsant, number two is adding antidepressant, adding opioid like tramadolol hydrochloride, and finally you can go for, if it is failed, so you have to take the help from the interventional side. That is interventional, it works very well. So you can go for the selective nerve root blocks. So you can go for the dorsal root ganglia pulse radio frequency, and you can go for spinal cord stimulator also. But it is very expensive. First try with the conservative part. If it works very well with your multi-drugs therapy, so treatment should be up to that level. If it is failed, then you can go for the interventional part. I think you got the answer.
I think Dr.
Thank
Kausar,
you
I
so
think
much, sir.
I would like to add to what Dr. Kausar said. Actually, we had a much simpler solution, Kausar. Actually, we had a very good preparation, but unfortunately it got banned from our DCJ, that is Drug Control Government of India. That was a combination of ketamine with amitriptyline. See, I strongly believe in think globally, act locally. The scar pain is a local pain. If I can get rid of that particular pain by applying a local application of some kind of gel or some ointment or whichever you would like to say, that was really helping, ketamine with amitriptyline. But unfortunately, people started abusing that one, using it like a toothpaste just to get a kick out of ketamine from that particular molecule. And the product was withdrawn. It was in case you can get that particular, but that's what I'm trying to say is everything you try to do is like, it's like a knife. I think we're taking too much of time. I think Monica is
Sir.
becoming restless because next speaker also is waiting, I think, probably. Because we can chat about it later, I think, probably. Ketamine plus amitriptyline.
Ketamine, yeah, I agree with you. Ketamine, it works well. Continuous 5 to 7 days continuous everyday infusion.
No, local application.
Local application. No,
on the scar.
Under the scar. Yeah, no, I have not tried yet, but yeah,
right?
theoretically, definitely possible. And I think you have the practical experience also. I agree.
So sorry to interrupt your wonderful discussion. I think we can carry it on later, and we will move ahead to our next session, sir. My apologies.
No, it's okay.
For that, we invite Dr. Anjali again to introduce the
Thank you,
chairperson
Monica.
and speaker.
Sir, that was indeed a very informative and interesting talk, inviting a lot of interactions. But as we have to go ahead, I would like to thank Professor Kausar Sardar sir for a wonderful talk. And I would also like to thank our esteemed chairperson, Dr. M.D. Khalilur Rahman, Professor Debabrata Bane, and Dr. Murlidhar Joshi. Now, I would like to invite our chairperson for the next session is Professor Amir Babu Shrestha. Professor Amir Babu Shrestha is professor and department head, Department of Anesthesiology, Manipal Teaching Hospital, Pokhara, current SAN president for the year 2023 to 2025, past head of the department, hospital director, Paropkar Maternity and Women's Hospital. I would also like to invite now Dr. Vasudev Parajuli. Sir is lecturer in the Department of Anesthesiology, TU Teaching Hospital, Maharajganj Medical Campus, Institute of Medicine. He's current General Secretary, Society of Anesthesiologists of Nepal for the year 2023-25. And he has multiple papers in national and international journals. I welcome you, sir. I would like to invite our own Dr. P.N. Jain, sir. P.N. Jain, sir, is professor in Department of Palliative Medicine, Tata Memorial Center, Mumbai. And he is consultant anesthesia, Tata Memorial Hospital. He's working there since 1992. And he has various honors and awards and publications to his credit. He has about 90 pain publications in international and national journal, more than 250 lectures in international and national pain fora. He's WHO expert on opioid policy guidelines for the year 2018, ICRA Best Research in Pain Award 2016-17, and he's recipient of Lifetime Achievement Award for the year 2022 ISSP. We invite you, sir, as chairperson. Now, basically for this particular deliberation, I would like to invite our speaker, Dr. Ninadini Shrestha. Dr. Ninadini Shrestha is Associate Professor, Department of Anesthesiology. She is working in Teaching Hospital, Maharajganj Medical Campus, Institute of Medicine, TU, and various honors and awards to her credit is Joint Treasurer of Society of Anesthesiologists of Nepal, Past General Secretary of Nepal Association for the Study of Pain and Fellow of International Pain Physician and Certified Interventional Pain Sonologist, awarded by World Institute of Pain, ASA Global Scholar for the year 2016. I think the purpose of this guidelines basically is to optimize pain control, minimize side effects, adverse outcomes, and the cost. And I think to enhance the functional abilities, physical and psychological well-being, and to enhance the quality of life for cancer patients. So I would like to invite Dr. Ninadini Shrestha to enlighten us on the topic, evidence-based guidelines on cancer pain management. Dr. Ninadini Shrestha. A polite reminder for all the attendees to put their questions in the chat box. Ma'am, are you there?
Hello, are you able to hear me?
Yes, please.
Yeah, okay. So namaste and a very good evening. It's a real pleasure and honor for you to give me this opportunity. And it's such a wonderful, warm forum because I have my respected seniors from my Society of Anesthesiologists of Nepal as the chairperson, respected Dr. P.N. Jain as the chairperson. I have to acknowledge Dr. Mudidhar Joshi sir, my mentor, and I've done my pain fellowship under him as his first WSF fellow, and I still follow your clinical practice. I think it's thoroughly, it's an honor to have you with us. And also, I'd like to acknowledge Professor Divekar ma'am, because my professor, Dr. Roshna Amatya, whom I am very close with, she remembers you thoroughly and talks a lot about you, and I hope to meet you someday.
Thank you.
Okay, so without much delay, I think I should start sharing my screen. So I hope you're able to see my screen.
Yes, it is visible. You need to put it full screen.
Okay, so is it full screen now? Okay.
Yes.
So I'm going to talk about evidence-based guideline on cancer pain management. It's a big topic, and it's beyond the scope of one 30-minute class, I think. But still, I'll try to justify talking about the different pain management modalities that we use in our patient and the evidence behind it. I have no conflict of interest. So I've made it very simple and concise because I think it's very important for us to talk about the evidence behind the practices that we do while treating cancer pain patients. So it's just a short introduction, and we're talking about the European Association of Palliative Care recommendation on opioid use in cancer pain. Then I'll be talking about interventional pain management, as I'm an interventional pain specialist, and the evidences behind it, and the future direction with the newer drugs in cancer pain management. So as we all know, I think everybody has more experience in treating cancer pain than I do. But it has been seen that in 2020, the United States has estimated 1.8 million new cancer diagnoses and more than 6 lakhs cancer deaths per year. That's a huge alarming number. And I think our statistics are also growing in newer cancer diagnosis and cancer-related deaths. The problem with this data is that the moderate to severe pain occurring in cancer patient is approximately 35%, and 80% of the patient with advanced stage cancer suffer with severe pain, severe refractory pain to treatment. Also, the concern study has been published where they evaluated cancer patients who present to the emergency room with acute symptom, where 62.1% of the cancer patient report pain as the primary problem. The WHO has established a step ladder on opioid treatment since 1996. And it is the most adopted worldwide method of cancer pain management. But still, it really lacks an up-to-date evidence, knowledge, and the availability of opioid, which has obstructed the path to effective relief of cancer pain. It's not only the availability, but the skilled use of opioid analgesic is very, very crucial to cancer pain relief. And there's a shocking lack of evidence to support clinical practice even after so many years of its existence. And another thing that's very alarming is that cancer pain causes disability for active cancer patients on average of 12 to 20 days per month. And even for patients who survive cancer, They continue to experience pain in 20%, and the functional limitation years is 50%. So cancer pain management, I think, is a very delicate balance between many, many factors. Among them, the most important one being the patient's general condition and the co-medication with a lot of medication, oncological treatment, as well as other treatment that goes on side by side. The nature of the pain, the experience, the stage they present to us with, the different interventional pain management modalities that are treated. The most important, I think, in my part of the world, the cost effectiveness and the availability of the treatment options. So I'd like to start talking about the EAPC, evidence-based recommendation on use of opioid analgesic in the treatment of cancer pain. It's one of the most cited and most recommended evidence-based guideline on opioid use in cancer pain. I suggest anybody who treats cancer patient should go through this. And it has more than 1,700 citations, was published in Lancet in 2012. But still, till date, it's the best recommendation that has been available. So EAPC recommendations has highlighted few important things. And we have to, I'll not go in much detail, but I'd just like to highlight some important recommendations that they present. So WHO Step 2 opioids, they have weak recommendation on use of different drugs like codeine and tramadol, which they've listed in the guideline. They have very strong recommendation for use of morphine as the first choice opioid titration. For when you're doing opioid titration, they have very weak recommendation on how to do the opioid titration, because when we first start patient on an opioid and when you titrate the dose, it's a very weak recommendation on oral morphine. The role of transdermal opioids is a very good recommendation, strong recommendation in patients who cannot take oral opioids. They have a choice of either parenteral opioids or transdermal opioids like fentanyl and buprenorphine. The role of methadone in cancer pain. Methadone is a very complex, long-acting opioid, but it has to be used by skillful people who have experience with it. And apart from other recommendations, the most strong recommendation that they suggest is when there's complication related to opioid, like emesis, CNS symptoms, or constipation, they strongly recommended use of other adjunct drugs for the prophylactic treatment of the opioid-related side effects. So while talking about interventional pain management, I'll be talking on these 6 headings. I'll be talking about epidural and intrathecal administration of analgesics, patients who have unilateral pain with very limited life expectancy, patients with upper abdominal pain due to cancer of the pancreas or stomach, visceral pain due to pelvic tumors, perineal pain due to pelvic tumors, and spinal pain related to vertebral compression fracture. I included them as interventional pain management topics because I think these are the ones which are most common that we deal with. So while talking about evidence-based guidelines for interventional pain medicine, there are a lot of guidelines that has been suggested by different societies, but yet there is not one which is widely accepted and followed. So apart from all these interventional pain medicine guidelines, I find 2 guidelines very comprehensive, and I try to follow them in my practice. So one of them is this one, evidence-based medicine. It's a chapter number 23, Pain in Patients with Cancer by Chris Vesses and team. Another guideline, which is quite comprehensive and effective, is the American Society of Pain and Neuroscience Best Practices and Guidelines for Interventional Pain Management, which was published in 2020 in the Journal of Pain Research. So formulating a guideline is a very difficult task, and I really appreciate trying to formulate a guideline in a cancer pain, which is as complex and as dynamically changing and very difficult to treat. So as you can see, this Prisma diagram where they have included more than 1 million database searching from PubMed, Medline, Cochrane Library, and Embase. And from screening to different exclusion criteria, and eligibility criteria, they have included only 89 papers out of that many. And from that inclusion, they have determined the level of evidence. The recommendation is based on the grading strength of recommendation and quality of evidence in clinical guideline, the GRADE, based on Goyat et al. And this is the summary of evidence scores and implication that they have followed, where 1A plus till 2B plus is a positive recommendation. 2B to 2C plus is a considered preferably study related. 0 meaning only study related but not recommended, and 2C minus to 2A minus as negatively recommended. So I'll start talking about epidural and intrathecal administration of analgesics. So this route of administration is basically used when there are two problems. When the patient with pain cannot be sufficiently relieved with the conventional treatment, which is opioid analgesics along with the adjuncts. When the side effects prove intolerable despite aggressive treatment, and they cannot tolerate those conservative treatment plans, and the pain that cannot be treated with other modalities. So that there are a lot of, I think this is the most evidence-based treatment modality that we have in literature. There are lots of RCTs, prospective studies, systematic reviews, which have demonstrated very strong recommendation, analgesic efficacy, and side effect reduction. They've also done a cost effectiveness study where they have established that it's quite cost-effective treatment plan for a cancer pain patient. In 2017, Dear TR et al., the Polyanalytic Consensus Conference recommended intrathecal drug infusion systems, best practices and guidelines, which is, I think, widely accepted and followed. This is just a chart where they recommended the catheter tip location based on the pain, and they also recommend the use of bupivacaine infusion protocol based on this catheter tip location. So this recommendation for epidural and intrathecal catheter is not only for the internal drug delivery system, but is also for the external drug delivery system. The effectiveness of this intervention has been reported in many studies, like 31 studies involving a total of 1,343 patients. The intrathecal delivery was studied in 28 cohort studies involving 722 patients, and the most frequently used opioid being morphine. It had good to excellent analgesic effect with 87% in intrathecal and 89% in epidural groups. The FDA has approved 3 medications for its intrathecal use: morphine, juconotide, and baclofen. And the PACC guideline recommends off-label drugs like fentanyl, sufentanil, hydromorphone, bupivacaine, and clonidine only when the FDA-approved drugs are attempted and failed. The pain intensity also decreased significantly with the use of this delivery device at the time of hospital discharge. However, all these devices in my setup is pretty expensive, and my patients can hardly afford them. So we rely on the external drug delivery device, and the evidence for external drug delivery device is useful if the life expectancy is less than 3 months. So the summary of evidence for epidural and intrathecal medication delivery: for intrathecal is 2B+. It's a good recommendation. And for epidural is 2C+. And so the recommendation is that intrathecal delivery is recommended more than epidural delivery for refractory pain due to cancer. Now going to the next topic, unilateral pain with limited life expectancy. I'm talking about patients who have Pancoast tumor or pleural mesothelioma or invasion of brachial or lumbar plexus with the cancer treatment, being uncontrolled. So if the patient has below the shoulder pain or below the dermatome of C5 pain, then lesioning of the spinothalamic tract at the C1 to C2 level of the spinal cord with the aim of relieving unilaterally refractory localized pain below the level of C5. The important decision-making thing for this intervention is the life expectancy. The life expectancy cannot be more than 1 year if we are planning this intervention. This is not practiced, I believe, in many parts of the world. There are very few centers in the world who specialize in practicing this technique, which is also called as cordotomy. While going through the literature, there are 6 case series which describes a total of 677 patients with cancer who were treated with unilateral cordotomy. And they have reported excellent pain reduction, like 82% and 98%, like even complete pain reduction with this, with the opioid consumption reduction by 50%. But the best results were obtained in the treatment of unilateral pain. However, it is very probable to have complications like paresis, which is 10%, bladder dysfunction, 15%, and respiratory depression up to 10%, as well as other dysesthesias. So this is just an anatomical representation of the chordotomy, where if the pain, as you can see in the picture, is below C5, we can do this procedure while putting the needle in the anterolateral spinothalamic tract between C1 and C2. I just wanted to show this picture to show this dentate ligament, which is actually a protective ligament which prevents the drugs or the dyes that goes to the dorsal surface of the spinal cord, and we can also use dye to delineate where our needle is. This procedure is done on the fluoroscopy, but mostly it's done on the CT guidance for safety of the patient. So the recommendation is a weak recommendation with for unilateral cancer pain below C5 with a life expectancy being below 1 year only, with a skillful hand, under a skillful hand. Next, I'm going to talk about upper abdominal pain due to cancer of the pancreas or stomach. I think there are a lot of literatures on this now. So basically, we do sympathetic blocks or neurolysis of the sympathetic chain. They are utilized for severe visceral cancer-related pain. And demarcated by the anatomical structures, we select different plexus for different parts of the abdominal pain, like from the esophagus to the transverse colon. We choose the celiac plexus. For lower abdominal and pelvic structures, they are supplied by the superior hypogastric plexus, and the ganglion impar for the perineum, distal rectum, distal urethra, vulva, and distal third of the vagina. So I'll first talk about the celiac plexus block. I think there's very strong evidence, and there are many papers, very strong papers, who talk about the quality of the celiac plexus block, different techniques that have been described, time tested and researched upon. So I'll just talk about a few highlighting papers. So an RCT done in 1997 was the paper which established that cervical neurolysis in cancer prevented deterioration in the quality of life by the long-lasting analgesic effects. Then another RCT in 2017 by Fakio Russo. He was the one who compared celiac neurolysis with local tumor ablation versus celiac neurolysis alone. And he demonstrated superior pain relief and better survival in a combination. Another RCT, that patient randomized to celiac neurolysis before step 2 on the WHO ladder had better pain control and quality of life compared to those who are randomized after they failed to achieve analgesia with step 3. This was one of the landmark articles which has advocated now to the WHO, first of all, for the inclusion of interventional pain management as the 4th ladder, and now they want the 4th ladder to be included at around step 2. Another RCT by Dolly et al. In 2018, it compared various volumes of neurolytic medications, which was dehydrated alcohol, to evaluate the efficacy of different volume of 70% alcohol for pain relief in cancer pain. And they found that the higher the volume, the better was the outcome with the pain relief, with the quality of life, and with the reduction in opioids increase. So they found that with the increasing volume, which is 40 ml being the most effective of the 3 volumes studied. Another study by Pang, J.Y. et al. In 2019, he compared a few studies with endoscopic ultrasound-guided celiac plexus radiofrequency ablation to alcohol neurolysis and demonstrated better outcomes with radiofrequency ablations. So just few pictures to highlight the neurolytic celiac plexus block, where we can see 2 bilateral approach, one anticrural, one on the retrocrural. And there are lots of techniques described in the literature, and there are lots of papers comparing different techniques to see which yields better result for the patient. So talking about splanchnic nerve block. So splanchnic neurolysis is done for the splanchnic nerve, the least splanchnic nerve at T12 level or T12 level. T11 or T12 level, and the splanchnic neurolysis has superior results compared to celiac plexus neurolysis for pancreatic body and tail cancer specifically. And if you have patient with pancreatic body and tail cancer, it has a very strong recommendation which was published in 2004. So the summary of evidence shows that celiac plexus neurolysis has 2A plus recommendation and splanchnic nerve neurolysis has 2B plus recommendation. For cancer-related moderate to severe abdominal pain that is refractory to analgesics, celiac plexus neurolysis should be performed, and flank neurolysis should be considered in patients with abdominal cancer-related pain due to advanced pancreatic cancer in the body and the tail. And they also recommend early neurolysis to have better outcomes. Now, talking about visceral pain due to pelvic tumors. I'd like to quote this article which was published in Pain Physician 2020. It was one of the largest retrospective study which was done for visceral pain management in pelvic tumors. 180 patients with malignant pelvic pain undergoing superior plexus hypogastric neurolysis by fluoroscopy. They obtained a 48% decrease in pain score and 55% decrease in opioid consumption that persisted at 3 months. So the fluoroscopic guided technique, where it's not a transdiscal, it's the approach where we just go through the vertebral body and do the superior hypogastric plexus block neurolysis. The evidence being 2C+, so it's a weak recommendation for using superior hypogastric plexus block for patients with visceral pain due to pelvic tumors, because I think we still lack a lot of evidence. There are very few, most of the things are case reports, and the strongest article that we have was the one that I just discussed. So the Mercadante et al. Did a systematic review for this in 2015, and even EAPC recommendations say that it's a weak recommendation for patients with visceral pain.
Ma'am, sorry to interrupt. You have 5 more minutes.
Okay, thank you so much. So now talking about the perineal pain due to pelvic tumors, the nociceptive and the sympathetic supply of the perineum, distal rectum, distal urethra, perianal, vulva, scrotum, and distal third of vagina is from the ganglion impar. And the perineal pain due to pelvic tumors are very disturbing, and the interventions that we usually offer is the ganglion impar block along with the saddle neurolysis. So there are very limited data, and the data is just limited to case reports and case series on these. And for the ganglion impar block, it has consistently been showing improved pain relief with not much significant adverse effects. Whereas with the saddle block, it's a very neurolytic procedure where we give intrathecal phenol in the saddle nerves, and with a very good result, but it can only be done in patients who have no who have very less life expectancy and who have no urinary or bowel control. So, so talking about ganglion impar block, Plancarte et al. Was the first person who reported this block in 1990, and his was the first study of 16 patients with advanced malignancies and significant pelvic pain, which found a 60% improvement in pain symptoms following a neurolysis of this ganglion. Pain improvement of more than 60% was reported in 2008. And after this, there are only few case reports and case series for ganglion impar block. So the recommendation evidence for perineal pain due to pelvic tumors for lower sacral root or of cauda equina phenolization, that is lower end block with alcohol, is 0, because there has not any study that has been published. There are some chapter written in the books, but there are literally no literature. So ganglion impar neurolysis should be considered in patients with intractable perineal cancer-related pain is 3B. I think it's one of the this art of pain management for cancer pain is getting lost, because I think it sounds very horrible. I know we're putting alcohol in the nerves, in the CSF, but I think for a country like ours, we have a lot of resource limited setting with good skill training and with a lot of volume of the patients that we have, I think this can actually be a boon for a setup like ours, where patients are terminally ill, they already are bedridden, and they are like suffering from severe refractory pain, not responding to any medicine. I think these interventions really help them to end, and they are going to die pretty much soon, but it's very devastating, not only for the patient, but also for the patient's family in cancer pain, and when they're terminally ill. And I think these interventions need to be not reinvented, but they need to be reused and again brought into our clinical practice. So the ganglion impaired nerve blocks and neurolysis. It also lacks RCTs, but they have a lot of case reports and case series where perineal oncological pain had been shown to be effective and safe as well in helping with these pain conditions. A lower end block, again, should only be considered when patient experience pain in the small pelvis and have lost the normal bladder and rectal function. Talking about spinal pain related to vertebral compression fracture, almost many patients have this complication as their cancer progresses because it's anterograde, retrograde, the vascular metastasis to the vertebral spine is quite common. And there are a lot of treatment options, conventional therapy being analgesics, bisphosphonates, and radiotherapy, the interventional being the vertebral augmentation and radiofrequency ablation. There are very good papers, very good systematic review for vertebral augmentation, which have shown very good result. And if you compare vertebroplasty with kyphoplasty, both have good results, and none of them are superior. Radiofrequency ablation with or without cementation also shows very good safety and efficacy for spine metastasis pain and a rapid rate of pain relief, even rapid than the radiotherapy. So it has efficacy of 0 to 2 weeks. The evidence being 2B+, which is a good recommendation. So the future direction, there's a drug, which is resiniferatoxin, RTX. It's a potent agonist for TRPV1, which is expressed on A delta and CNF fibers. It is given intrathecally, where it targets specifically in the dorsal root ganglion and the primary afferent spinal nerves, and effectively spares all the other nerves, the motor, proprioceptive, and sensory cell bodies, and gives pain relief in cancer pain. So there are a lot of studies been going on. Currently, presently, they're doing a multi-center blinded control phase 3 clinical trial. And I'm really looking forward to this drug. I know by the time it comes to us, it will be many, many years, but still there's a hope that we'll have some drug which selectively affects the sensory and not the other nerves. The pain fibers and not the other sensory fibers. So thank you for your patient hearing. This patient awaits my consultation today itself. So I just wanted to share how devastating a cancer patient is in his deathbed. And I feel really emotional because whenever I see a patient like this, it's they know that they're going to die, but all they ask is some pain relief. And I really hope that we will be able to provide good pain relief for patients like this. Thank you so much.
Thank you, ma'am. Over to Monica. Monica for the question answer session.
As of now, we don't have anything in the chat box. If anyone wants to discuss something, they can raise hand and unmute themselves.
Dr. Ninalini.
Yes, sir.
And it was very fantastic lecture. You speak so well, and my best wishes for your future.
Thank you so much.
I am surprised that you have not named the WHO guidelines for cancer pain. You have not touched upon that. There are WHO cancer pain guidelines 2018, which includes all the papers, whatever you have shown here.
Yes.
After that, they have developed very comprehensive WHO guidelines for cancer pain. And you have not shown the WHO letter also. So that is the basics for teaching. A lot of your first timers would be there who would be listening the lecture for the first time. And these interventional pain management actually things are just 5% of the total population where they are employed. Basically, 95% of the patient will be treated by oral analgesics. So you should emphasize on oral analgesics more, and how the side effects management is done, how the morphine is given, how the NSAIDs are limitations have in the cancer pain. And then, of course, in neuropathic pain has been taken care of, so no need was there to touch upon that. So that is, what do you want to say on that?
And so thank you very much, and I really appreciate opioids take care of 70% of the cancer pain, and the severe refractory pain is only as per the evidence that they say 15 to 20% only. I thought the WHO ladder is discussed many times, and it has been well established already. So I just wanted to focus on the evidence guidelines on the intervention, which is very less discussed upon. So that was the only idea, and it was very short time to cover
your topic. You stick to your topic. your current evidence-based guidelines. So these are not evidence-based guidelines on interventional. Interventional is just a tail of the entire animal in the cancer pain. You understand that?
Yes, sir.
You
Yes.
speak so well. I congratulate you. You speak so well. You understand so well that you
No,
have
no,
told.
absolutely, sir.
You have told that we are in a resource-starved country and we should use these interventions much more, which is a dying art. So I appreciate those dialogues you have given. But oral analgesics are the basics of cancer pain, right?
Absolutely.
So
Absolutely.
very rightly said, sir. We have a question related to that also. So Mohammed Zuniad has asked, where does intervention stands in WHO ladder? You can just answer it.
So WHO recommendation in 2018. I think PNZ sir is one of the people who have formulated that guideline. So in front of sir speaking is really awkward, but I think it's now they have tried to incorporate it as the fourth step. When the patient is not responding to opioids, strong opioids, they recommend intervention. And but I think there are some evidences which has come up, which are specifically in diseases like in pancreatic pain, pancreatic cancer, where they have shown that patients who have they're done RCTs where if they do intervention in the start of opioids, they have better pain control and even increase in the life expectancy. So there's a big controversy going on whether we should wait for the intervention to happen only when everything has failed. Like all these strong opioids have not worked, other adjuncts have not worked. Is that the time for the intervention? Is a big controversy going on. Because interventions are very specific and target related. And I think with cancer, when it progresses, it really involves and changes the anatomy of the nerves as well. And when patient is already progressed far into the disease, it's very difficult to get results with interventions because the anatomy is already distorted. So I think that is the reason why this controversy is going on, because if we want to have any benefit with the interventions along with the opioid therapy, because it's not only for the pain management, it's also for the functionality, for decreasing the opioid uses, for decreasing the side effect related to opioids. It's one of the modality which can be very helpful in cancer pain.
Thank you so
Dr.
much.
Dr. Ninadini, there is no controversy on that. There is no fourth ladder as such by the WHO committee. There is no fourth ladder into that. There has been proposed that there should be a fourth ladder. Okay? Yeah. Next question, please.
So Dr. Hina has asked, which block is helpful in sacral root pain?
So for sacral root pain, it's very difficult to treat. And there are a lot of interventions that are done, but the evidence still shows that for sacral root pain, the best intervention is the sacral root, dorsal root ganglion PRF, but that doesn't have a very long-term outcome. So if the patient is terminally ill with life expectancy of less than 3 months, they still recommend saddle neurolysis.
The next question for you is, what opioid should be used? Okay, this is actually not related to cancer pain. First, we'll take the questions for cancer pain. So regarding RFA versus alcohol neurolysis, what are the evidences in case of celiac plexus and splanchnic nerve neurolysis?
So the evidence is 2B plus and 2C plus. And for celiac plexus and splanchnic neurolysis, there's a lot of strong recommendation for celiac plexus neurolysis because there are a lot of research papers on that. Well, splanchnic neurolysis is still, but the papers are coming up, and the recommendation is now that they're both equally effective for pancreatic cancer pain.
Thank you so much. So Dr. Nishant and Dr. Izhar has congratulated you for the wonderful presentation. And in addition to that, Dr. Izhar has asked a question. How important is a diagnostic block before a neurolytic block? What is the protocol to be followed, and should diagnostic and neurolytic block be performed in the same setting?
I have very limited experience with neurolytic blocks because apart from celiac plexus and splanchnic. So there are different neurolytics blocks that can be performed. So one is the common one, like we talked, the celiac and the splanchnic. But the other neurolytic blocks are intrathecal neurolysis, like we talked about in the saddle, or also at different levels that can be done for severe cancer patients with limited life expectancy. The diagnostic block is always a good idea before doing neurolysis, because chemical neurolysis, depending on the type of drug that we're using, alcohol or phenol, depending on the concentration that we're using, can develop a lot of side effects. So if we have good experience and we are very skilled at doing it, I think we can do the neurolysis without diagnostic block. But if there's a diagnostic dilemma, well, if you are trying to find out what the pain generator is, and there's a little confusion because the patient has severe pain on different parts of the body, then I think it's always better to go for the diagnostic block first.
And in chronic pain, how long we can use morphine, intrathecal morphine?
In chronic, like non-cancer
pain? Cancer pain. No, in cancer pain, as it is a chronic pain. So how there's a question that how long intrathecal morphine can be used?
I know that the intrathecal, if there's intrathecal drug delivery system, they can use opioid for a very long time. I have seen reports of around 8 to 10 years, but I don't know exactly whether there is a timeline of when we should, stop, or I have no idea about that. I'm sorry.
Okay, so is there any role of truncal blocks for pain relief, cancer pains?
Truncal blocks? As in like regional anesthesia truncal blocks, you mean, with local anesthetics?
Yeah.
Like lumbar plexus block, etc.
Okay. So lumbar plexus is a fairly, it's a complex plexus with even motor involvement. And if the patient is like already bedridden, if the cancer is like, for example, if there's a pancreatic cancer which has progressed and involved the psoas muscle and all the lumbar plexus is causing severe pain, patient is bedridden, terminally ill with very low life expectancy, then yes, they can definitely help. We can use alcohol. But if the patient is early on in the cancer diagnosis, is ongoing treatment for cancer cure, I think neurolysis in lumbar plexus is not a very good idea.
So Dr. Tadlika, you have raised your hand. You want to say anything? Dr. Tadlika? Please unmute, ma'am.
So good evening to all. I support her statement for the celiac plexus and the splanchnic block, which reduces for pancreatic cancers and pancreatic chronic pain. It reduces definitely the requirement of the morphine or other analgesics patient is on. And it is always a multimodal approach when it is a cancer pain. Though I don't treat much of the cancer pain, but it is the experience I'm sharing that I have treated many patients of pancreatic related chronic pain, and they were much better and they had reductions in that. So there was a question from comment from Dr. Jain sir that you should talk about more of the morphine and all. That is fine, but intervention definitely has some role in reducing the requirement of the opioids. Thank you. That was the comment I wanted to make. Thank you, ma'am.
Wonderful session and enlightenment by our seniors. Thank you so much, sir, and thank you, Dr. Nanadini. Now we are heading towards the end of this session, and I would like to request Dr. Virender Sharma, Treasurer, Saarc Association of Anesthesiologists. Sir, are you there?
Yeah, I'm there.
Welcome, sir. So I would request you for the vote of thanks and then the closing the session.
Thank you, Dr. Monica. Good evening, respected President Saarc Aa, Dr. Venkatgiri, office bearers of the Saarc Aa, office bearers of different societies in Saarc, learned speakers who really presented so well, respected chairpersons, senior faculty members from all the constituent associations of Saarc. Yes, I congratulate the organizers, especially Dr. Naveen, for choosing such a topic. And it was a topic of interest for all. And the best part is that gradually this is the second one, and more participants are coming from different societies. And that is the aim of such webinars, that the learned faculties and the anesthesiologists from different countries, they interact and discuss, and they can ask questions from experts from other countries. That is a very good initiative, and I'm sure upcoming webinars will have more and more members attending these topic related. The topic really you chose very well, and I'm sure in future we'll have such interesting topics which are of common interest to all. And I thank all the participants, all the listeners who have joined, and they have asked so many questions. It was really a very interactive and useful webinar. Thank you to all. Thank you very much.
Thank you, everyone. Thank you. Thank you, organizers, for inviting me.
And it was a pleasure to have Dr. P. N. Jain sir and Dr. Noor Arian and dignitaries from Sri Lanka, Nepal, Bangladesh, Afghanistan, and of course India. And I personally thank Dr. Anjali Bure and Dr. Monica Chikara. See you soon for the next Saarc Aa Cpdp program, where presentations will be from Pakistan, Afghanistan, and Maldives. Thank you very much. Good night.
Thank you so much.
And thank you, everyone. For this.
Thank you. Thank you, Dr. Virender. Thank you.
Thank you.
Thank you, Dr. Virender.